accelerator space, been on the venture capital side with the Koch brothers out of Wichita for a few years. But for the last 20 years or 40 years, actually, I've been writing code every single year, hands in it. For the last 5 years, I've been seeing the evolution, as you guys probably have, in what AI is capable of doing. And so we ran into these guys. They're 6 years or more into the game of applying AI to healthcare. And there's a couple things, we all know, there's a lot of problems to be solved. We talk about the three-legged stool in our practice, which is for us eligibility, prior authorization, and then the granddaddy of them all, which is if I have a fee schedule that says I get paid $1 for a procedure, I want to collect $1 for the same procedure, and that never happens, right? So AI is a tool that can be leveraged for this. These guys have figured out how to do it on that primary driver of everybody's healthcare business, which is RCM. But I also want you to pay attention to some of the other things that are coming out. Some of you may know the term agentic AI, and these guys are quickly rolling out functionality that essentially serves all of the frontline stuff that makes all your people tired of their jobs, want to have a lot of turnover and go do something else. Agentic AIs are how you leverage AI to do the job that is otherwise somebody's doing and sitting on hold music, listening for eligibility or a fax back or trying to get documents in for prior authorization or find out where status is or schedule a patient, okay? So those tools are coming along as well. With that, I think I'll introduce Daniel Stewart and Greg Martinez and let them take it from here.
Thanks, Dave. Good morning, everybody. My name is Greg Martinez. Like Dave said, appreciate the introduction. Our background, and we can kind of roll through here, is we're both physical therapists. We have doctorate degrees in physical therapy. We practiced for a number of years. I practiced for about 10 years in private practice before making the change into the technology space. And then Daniel came over with me a few years ago as well to start helping reform the way healthcare is rendered across the US. So a little background on kind of the why behind us going. This is what we'll cover. So we'll touch on who we are and where healthcare is at today. Like we talked about, we'll go through a few of our options here as far as ambient solutions, revenue cycle like we talked about. We'll touch on the EHR and then go through the agents, and then we'll kind of tie it all together to wrap up. So basically, wanted to just touch on this to set the stage, okay? So medicine as it currently stands is very complex, and in my personal opinion, unsustainable, right? For both providers, administrators, and patients. As you see on the data here, 61% of physicians say the number one case of burnout is because of too many bureaucratic tasks. There's just a lot of bloat in healthcare right now, right? And then for administrators, again, annual spend is $266 billion on administrative overhead just in the US in healthcare. And then lastly, from a patient side, 70% of Americans feel the healthcare system fails to meet their needs in at least one way. Basically setting the stage, right? In all three aspects, there's room for improvement. So then walking through a little bit of my story just to set the stage and walk through more of our product lines, Daniel and I. So again, practice for 10 years. Here's the issue. I grew up in Utah, I practiced in Salt Lake, okay? And I saw about 30 to 35 patients a day. At that time, Medicare continuously was decreasing the fee schedule specifically for physical therapy. Our cost to render care was consistently going up and our margins were shrinking, okay? So at that time, I had to decide for myself, what are my options in this field? And as you can see, basically the number one thing we all think of in medicine is, I guess we're gonna have to see more patients, right? If we have smaller, lower margins, the only way to keep the doors open and continue to render care and provide medicine, because of why we went to school to do so, was to just increase our patient volume. Go from 30, 35 to 40, 45, 50 a day, right? Which, as you can all tell, right, that is not what I wanted to do. That's not positive for any of those three parties that we mentioned in the previous slide. And as we did that, not only did I have less interaction with my patients, I was less fulfilled. I had less of a relationship with them. But at night, I would go home and document for 2 to 3 hours a night, and I'd wake up early, get to the clinic an hour or two early, just to prep for the day because there's so many patients I had to see. That's not good for me. I'm starting to burn out, right? My patients are getting worse care, and the system's continuously breaking. Okay? So next, other option is, I could change fields. I didn't want to change fields. I love being a physical therapist. I love rendering patient care, and that's why I went to school to get a doctorate degree. However, In our specific field of rehab, our turnover rate is 9% compared to about 3% across other specialties for reasons just like this. Right, our margins are low. Right now, there's about 15% of rehab professionals at this point in time looking to get out of PTOT speech as it currently stands. And that's alarming because we already know there is a healthcare provider shortage across the US, right? So what can we do about it? Basically, I came to this point where the only way I could figure out how to do this was, how can we collect more per encounter and actually optimize our practice through automation, technology, AI. And so I set out on a journey to figure out a way to do just that. And the company that I found to help provide those solutions is called Athelas. Right? We've recently gone through a merger with a company called Commure, so we're kind of referenced as Athelas Commure at this point in time. But I did end up leaving, that point number 2, full-time patient care as a physical therapist to go and try to help the bigger picture and start treating instead of one-to-one, start affecting one-to-many, and seeing if we could actually improve the way that healthcare is rendered on a day-to-day basis in all fields, not just physical therapy, but across all specialties across the US. Okay? So here's the general suite of what we offer at Athelas Commure. We won't go through every single one of them. We'll touch on about 3 of them today. Top left is streamline. That is a nurse safety duress tool. So at any point in time, you're tracked through a system. There's any risk at all that a provider feels, and again, nurse safety is a huge issue right now, especially post-COVID. They can push a button and immediately have backup or support at any moment, including around the facility of a hospital, parking lot, etc. Scribe will go through, so this is the ambient documentation solution. And we'll talk a little more about this. We just signed an agreement with HCA to roll out Scribe to all 45,000 providers. So this is about a 2-year rollout that we're working on now with HCA. Engage is more of a CRM platform. RCM, I think, is where we'll spend a lot of our time because it is the foundation of really how medicine is rendered. Our EHR is actually being refined as we speak. We rolled it out to, again, rehab, but ortho, we're expanding into cardiology and other specialties as well. And then lastly, the company actually started on RPM and remote devices in patients' homes as well. Okay.
Yeah. So when it comes to our product lines, we actually service quite a few hospital systems, independent practices across the country. So you can see some of the logos, some of them that I'll point out. Again, HCA is an exclusive partner of ours for our ambient scribe tool, along with Tenant. We just signed a contract with Summa Health, which, if you're familiar with that organization up in Ohio, it's about a $2 billion hospital system that we're really revamping the entire back-end processes when it comes to the way that they look and process payments and how they use AI in their systems. At scale, obviously, when you start applying AI at scale, we have about 500,000 providers using the software, $10 billion annually flow through our systems, and about 100 million patient interactions through our engagement platforms in 2024 alone. So when we talk about investors, and more, we just have these slides, not necessarily to tout that we're really great or awesome, but a lot of times when you run into these companies that tout AI, they're a team of 5 to 10, maybe 15 people that are mostly engineers trying to create a problem or trying to solve a problem. What we're trying to show here is that we have the backing through General Catalyst, through Sequoia Capital, NVIDIA is an investor of ours, where we're actually making a difference in the space across thousands and thousands of practices today. So in the last 120 days, our company acquired a company called Augmetics. Augmetics was one of the first ever virtual scribe companies where they essentially hire somebody overseas to follow a doctor around and basically scribe their notes and put it into their EHR with them. They also developed one of the first ambient solutions. We acquired them, I think, for about 130 million and brought them from a public company to a private company. We then signed HCA to operate in all 380 hospitals, I believe. And that was our first Meditech integration. Tenant Health was then signed shortly after that as an exclusive partnership for our Scribe product. I touched slightly on Summa Health, which is an Epic integration, and then we acquired Memora and partnered with Vizient just in the last 3 months. Any questions? I think Dave said that occasionally you guys ask questions during, sometimes it's post. So
They'll find one and just go for it.
When you list those health systems, what service are you providing? Is it the scribes or
Great
is it
question.
the medical record? What?
Yeah, that's an amazing question. So the vast majority of the larger systems we're rolling out kind of customized solutions to. So like if we look at our relationship with HCA, we have another product called Patient Keeper that sits upon their EHR and helps with coding, helps with appeals management, stuff like that. We customize something for Tenant Health that works on their back end, kind of the RCM cycle, but they're largely a scribe partner. A lot of smaller hospital systems we're starting to do full revenue cycle for. We just signed a couple hospitals to help us adopt our EHR to be able to operate in a hospital system. So not all of these logos up here are using all of our product lines. A number of them may just be using our streamline tool, which is a safety tool. But I think, from a relationship standpoint, I think we're in 5 of the 10 largest systems in the country.
Is the EHR a full replacement for their HR, or is it augmented with the HR?
Yeah, so it's meant to be a replacement. Yeah.
So that being said, when you have these different companies that are using your product for EHRs, still information sharing is very much a push kind of data situation between organizations. Are you working or plan to work for AI to help like medical records transfer between different companies?
It's a great question. And if you didn't hear it, talking about data transfer, especially on the EHR side. So the great part about it, because we have such a robust suite of products, is what we'll do is to transfer data from one EMR to ours is we use Scribe. And so what we can do is actually ingest all historical data for all patients across any period of time. And within a 2-day period, we do it over the weekend, ingest it, and then not only are you just getting like a PDF uploaded into a patient's chart, more so you can actually convert the data into the format of our EHR. So our EHR is called AIR. And so you can take all previous, whether note types, right? It could be a procedure, it could be an initial evaluation, a progress note, a discharge summary, you name it. And we can take that format, convert it directly into our format via Scribe. So it ingests everything, converts it, and so then you can actually reference it. You can actually edit as you go, not previous notes, but as you go. And then what you can do is you can say, hey, also, could you just give me a summary, a brief summary of what's happened with this course of care with this patient before I render care net new? And so you're not scouring through, months of data from previous encounters to know what's going on. You can actually say, hey, AI, just summarize these key points for me, and then it can immediately start to render care at the start of that encounter.
I'm curious to know more about kind of caught my attention with the comment about the EMR in the hospitals, because our industry needs more players in the hospital EMR space.
Yes.
Can you talk a little bit more about about what your strategy is there, kind of where you fit?
It's a fair point. Yeah, I'll give a little background. I'll give a little background on the why behind the EHR. To be very transparent, right? That was not on a roadmap. I think that's an important point for us, because as a company, we didn't say, let's go take on Epic and Cerner, right? What we did is said, let's go solve problems for providers and systems out there, and then let our customers guide what we do next. And so we have a very, very strong emphasis on something called forward deployed engineers. And so we have our team go on site to these systems, for example, HCA. Had we win the Scribe agreement, we went in there every other week on site, and they said, hey, if you can solve our ED billing issue, or documentation issue, you can obviously do any specialty. So every other week we sent our engineers on site and we said, hey, how does it look now? They said, it's not good enough, change it this way. We went back, changed it, came back. For a year we went every other week. Until they finally said, hey, I think this is good enough to pilot, and then they said, this is great. We solved ED, and we can do everything across the system, right? Next thing was, RCM is going great. We're scaling across the country. We'll go through the numbers on RCM. But people are then saying, hey, wait, you have documentation, you have RCM, why do we have to integrate into another EHR? Why can't you just have it live in the same place? And so that was why we even started going towards an EHR to build it. So the full platform has one place to live. there's not bolt-ons. A lot of pain, as you guys can all relate, right, is integration and bolt-ons, and how do you get data from one place to another out, disruption. An EMR does an update, and all of a sudden your integration needs to be redone and updated, right? And so the ask was, can this live in one place? And so what we have is our current partner, we have an advisory board of active sites on our SIM using Scribe or the product lines, and they're literally guiding the specificity on the build out of the EHR as we go. And they're taking, for example, one location's taking 40 sites and saying, hey, let's pilot AIR, which is the EMR, and we will dial this in until we feel like it's 100% ready to get off of ours and move to yours. And then all these workflows are completely optimized because all the platforms live in the same place. There's no more bolt-ons, no more integrations, it's just one joint suite. Makes sense. Yeah.
How safe is the system? Cyber attacks,
So it's compared.
emergency, power shutdowns and whatnot.
Yeah, I mean, and you're talking to two physical therapists, right? So from a technical standpoint, I know that we have like our SOC 2 compliance penetration test done. So from a security standpoint, I don't think, and this is my logic, this isn't anyone else's logic, but a lot of these companies wouldn't have signed up with us if there wasn't a pretty strong security background. But if you have more questions about some of that other stuff, I'm happy to set up a follow-up to go over it. But I'm not as technical as knowing some of those things.
Thank you.
Okay, awesome. So when we talk about simplifying healthcare experiences, we're really trying to do a couple things. One is have providers or help providers practice at their top of license, right? When Greg and I were in PT, practicing PT, the big standard of care among medical practitioners is, how do I practice at the top of my license, right? Instead of being someone who practices at the middle of your license or at the bottom of your license. And a lot of that has to do with the ability to put aside your computer, put aside your laptop, and focus 100% on a patient. So our Scribe tool does just that. We'll go into it in just a minute. For administrators, how do we give them real-time data into almost every aspect of their revenue cycle, the way that their providers are treating, how things are being coded, and how their patients are experiencing healthcare at their systems? We give real updated dashboards in real time so that administrators don't have to run spreadsheets, they don't have to pull CSVs and make their own spreadsheets, they can also live within our platform. And then finally, how do we use engagement tools to make the patient experience better when they come and visit a healthcare setting? So the first one is our ambient scribe tool.
Right, and this is just to illustrate. So looking at the numbers, say that we're spending 10 hours, which is conservative, right? Like I gave my story that is a low estimate. Say the provider's spending 10 hours of extra time outside the patient care document, okay? You start to calculate this, say that they are getting paid about $150 an hour, and this is all relative, right? There's unrealized revenue due to the documentation, about $1,500 there. Working weeks per year, 48. That's about $70K a year per provider. Say that you had 50 providers or physicians in a location, that ends up being about $3.5 million. Okay, and again, rough math, just to try to illustrate what goes on when we don't use our time wisely inside of patient care, and we don't have technology to support the way that we run our practices. Okay, so we keep going through this. A couple things here. This is ambient, and again, we're going to go over this pretty quickly. We do want to get to some more of the RCM features and functions, but from an ambient AI standpoint, there's multi-speaker speech recognition. You can personalize as many templates as you need. Now, again, to the question earlier, if this lives inside of our EHR, there's no integration required, right? Basically, remember this is ambient, this is not dictation. You're not trying to talk into your computer or your phone and have it just document exactly what you're saying, right? Large language models will take context with your entire interaction with your patient and actually fill in gaps and make some assumptions with your guidance. And so you just focus on patient care, have the conversation, it takes out anything that's non-pertinent to a medical note, and then auto-fills the entire document as you're going, okay? You can basically say stop recording, within about 10 seconds your entire note is filled out, And that can be as detailed as you want. That can be coding, that can be goals, that can be compliance checks, anything you want filled out automatically. Okay? And again, translation, about 60 plus languages now. It can do, as you're translating, it can actually show a transcription for you. If you're speaking English or speaking another language, as they speak, it will show you exactly what they're saying in English live time. Okay? And then, one more. Basically, one more time. You know what I'm saying. So, last thing I'd say on Scribe, again, this is so impactful from our start of our discussion and conversation. How do we let providers focus on what they went to school to do? How are we more present during patient care? And how does that influence the outcomes that we seek for the general population we serve? Right? And if we can be present, not only are we saving money to the previous slide, but we're actually giving back to the communities that we serve in. And that's, again, I'm biased, but that's why I went into medicine. And so, one tool, and think about this now layered on top of our other tools as we walk through some details in our sim.
One last note here, 30 seconds to finish a note or a chart. And it's really just looking it over and signing it off with one click of the button, which Greg and I probably would still be treating patients if this was out when we were practicing. Go ahead.
So question, if you have AI filling in a note or filling in what it thinks the doctor or physician would say, is there any type of requirement that the physician still has to okay that note? Of what
Absolutely.
AI filled in?
Absolutely. Yeah, so like Greg was saying, you have that conversation with the patient. We can actually templatize and customize how the AI writes out based on how the doctor wants the note written out. And then it will run through, and then within the EHR, we have embedded AI that reads what was put in there to make sure that it meets the compliance requirements of the company for that note for the insurance company that you're sending it to. And then it will also code the note, and obviously the doctor needs to make sure, they're certified coders need to make sure that the coding is what they intended it to be before submitting. But there always is that safety check.
What is your, to all the kind of logos you have up there, hospital systems and large corporate, are you planning on having this for ambulatory practices, so small organizations?
Absolutely. In fact, that's a huge part of our market. I think we show the larger ones just because it maybe gains a little bit of notoriety, but thousands of practices independent from single provider practices to thousands of providers are using it.
So you have API integrations into other EHRs as well?
Absolutely. Quite a few. Go ahead.
Yeah, so with the workload here, as the doctor is, treating a patient or taking a consultation, a lot of times, when you're talking about coding the visit, there's codes that are based on or paid according to time and obviously the procedure. So does with this evolution of how it works. And by the way, I'm a chiropractor here in Las Vegas. So
great to meet you.
Know what you guys are doing.
Yeah.
And so I've been in practice about 30 years, and you hit it right on the head about presence. So right now I'm using something where I can just talk, and it gives me a nice soap nose. But I still have to do the coding for the procedure I did, and for whatever billing I have to take. Especially in a town like this where there's a lot of personal injury. So I'm looking at things of whatever I'm saying on there, and then what I'm going to do, that will eventually code it so that way it goes into my EMR and I can bill out appropriately.
Absolutely.
Wow.
And one thing I'll say there is think about like AMA rule, think about AMA guidelines, right? Like that can be programmed into Stripe. So the nice part about this is there's going to be nuance per specialty, right? Insurance type, etc. All we have to do is train the AI to say, follow this rule set when you perform this function. And then you review it, and the more feedback you give it over time, the irony with AI is you have to be very direct with it. You can't be nice to AI or it doesn't listen well. Very, very direct. And you say, do this every time this happens. And then you check it. And so our providers that are using it more frequently now, they're to the point, like Daniel said, where they're reviewing, but not in a lot of detail anymore. They know that it checks the boxes, it's compliant, they trust the coding, right? In Cairo, there's 46 standard codes we use, right? For so, unless you have more modalities, right? but it becomes so efficient that they usually have signed and locked an encounter, then that encounter is automatically have a claim created for it and submitted before they even start seeing the next patient in the clinic. Is the workflow that's happening.
Okay, so revenue cycle. Everyone knows what revenue cycle is, correct? It's billing, right? I don't want to assume that everybody is at the same level for revenue cycle, because obviously when I, as a practitioner, was never taught revenue cycle before getting in this space. So kind of speaking high level in terms of revenue cycle management. Now, what I wanted to talk about specifically is that payers are starting to use AI to deny your claims. So this is an article by Cigna, and it's one of those articles that just make you pretty angry, right, about the status of our healthcare industry. But Cigna, a couple years ago, developed a program that essentially allows a doctor to mass deny claims without even reading or verifying any of the information in the claim. So the claims come in, the AI bulks it together by type, and then the MD reviews the reason for it and then bulk denies 50, 60, 70 claims at once. So they found, and if anybody wants this specific article, I can send it to you, is that Cigna denied over 300,000 claims in a period of 2 months, and they only spent 1.2 seconds per claim. So here we have your facilities that are inbounding phone calls or outbounding to patients with referrals, getting them on the schedule, collecting their demographic information, getting their copays, having the provider see the patient, all to have it be denied in less than 2 seconds. So Cigna, or ProPublica, followed those 300,000 claims, and I'd love to get a guess. How many do you think were ever resubmitted and actually paid out of those 300,000?
65%.
So 65% of claims, of denied claims are never resolved. That's actually misleading because it's a different article. But it was actually less than about 5% of those 300,000 claims. So 15,000 claims were resubmitted of 300,000 denials. So why do you think that is? Time, right? They know that the more that they can push back on providers and the companies that do the billing, with the state of the healthcare space right now, it's very difficult to go find the reason for the denial, fix the denial, and resubmit it. Prior authorizations. Who has to do with prior authorizations? Pretty much everybody in healthcare space. So this is an article that was done on a company called Evicor. Who's heard of Evicor? Anybody heard of Evicor? So Evicor is a company that sells outsourced decision-making on prior auths to healthcare payers. So they'll go to Blue Cross Blue Shield and say, hey, instead of hiring your own people to say yay or nay on a prior auth, if you give it to us, we guarantee a return on your investment. And so they have an algorithm, an AI, that essentially monitors Blue Cross's Blue Shield's prior auth denial rates. And as it starts to go down and the profit margin for Blue Cross goes down, they increase this dial. And what this dial does is they send it from an automated approval system to a manual review process, because they found out that whenever it goes to a human to decide if it's approved or not, that the chances of a denial go up. So let's say Blue Cross is only making $2 of their promised $3 return on investment. Evicor turns up that dial, sends more of the reviews to humans, and then the denial rates go up, and that return on investment comes back. Okay? To the point where the article mentions that at one point in 2021, Arkansas Evicor turned down almost 20% of all prior authorizations that were sent, which compared to the average across the country of 7. So what does this mean? It means that automation has to come to practices and hospital systems across the country using AI. The way that revenue cycle is done in the industry right now is you have a biller who goes to school, learns the background of billing, and then is at a company for 20, 30 years learning how to bill specifically for that company in that practice. And the problem with that is that intellectual property that all of you are spending on human capital leaves when that person retires, when that person hopefully wins a lottery, right? Or heaven forbid something happens to them and they have to move on, or they did another job, and that all that knowledge goes with them. Okay, what we're able to do is digitize that information so that knowledge stays with your company. So I think CAQH came out with a study that said on average it takes about 8 months to find, train, hire, and then 8 months to get to the level of the person you just lost. So that's 8 months of increased risk from billing performance based on that turnover rate. So this is a view of how we view revenue cycle, all the way from extracting the data, running eligibility checks, claims processing, running it through a rules engine, fighting denials using AI, and then sending out patient statements via text message, email, and paper. And as you can see, we've automated about 80 to 85% of the entire process.
Okay, let's jump into the weeds here. So this is a denial co-pilot. So basically, think of it this way: we have a group of denials that's come in, and what we deploy is our large language model. Okay, this large language model looks at the historical data of all common denial types, and then looks at thousands of pages of payer policy data, and it says what would be the most successful resubmission reason for a denial that looks like this. And say that there were, in this example as we put in the video, it shows a few, but this could be hundreds of denials at the same time. They're automatically categorized, okay? And then basically, as it comes through, we're able to ask the provider, which is a large language model. It automatically gives recommendations. This one says we need to check the payer policy. Brings that up. Automatically tells us what the details of the claim would be and why. Tells us payer policy and Utah Medicaid was not attached. So it automatically pulls the medical record from the CHR, which is Athena, and faxes it to Medicaid. Okay? And then basically it does a review of the medical record and says, is this correct? Perfect. Let's fax it. That's been faxed automatically. We can then resubmit the claim because that condition's been met. And then after that claim is resubmitted, which again can be hundreds of claims at a time if we needed to, what also happens is in this example, there's 25, is the AI then recommends a rule that says if we ever see this condition again, never let a claim be submitted the same way. So that denial type for this specific practice will never be repeated again, because we're now using AI just like insurers are using AI against practices like ourselves. Okay. Let's go forward. Let's go into some of our agents as well. Okay. So on top of this, we'll skip through the HR side. We want to show a couple agents. So again, Dave mentioned this. So AI-powered agents. Okay. So our agents currently have about 80 different voices we're using with them, and they can do thousands of inbound or outbound calls a minute. So we have a practice that gets about 3,000 to 5,000 calls a day. They can turn an agent on to fill all of those calls, whether they're related to scheduling, an outstanding balance, or even about a specific condition they're being seen for in the practice. Okay? And then that same agent can call to those patients to answer questions, to get scheduling, etc. So on this example here, so we'll go through, we're going to show you. As it's going through, we're looking at preferences. And we're saying, hey, you know what? What are the preferences we have inside of our EHR? We deploy an agent, and we just say, hey, this is when I'm available. And then basically it immediately says, update the schedule for that provider to only have these slots and only is available, right? So basically the way this moves towards is we can actually talk to the EHR using agents without ever having to manually type in the computer on a day-to-day basis. If you want to know anything about what's happening inside of your practice, you can immediately query the agent and uses a large language model and says, hey, what's my denial percentage for the last 30 days for this specific pair? Gives you the answer. If you want to say, hey, I want to block my schedule because I'm going out of town and I only want to see this many procedures at this time, just say it to the agent and it'll automatically update it. So all of the manual workflows that we use are time spent. It's inefficient. Now it's, hey, let them do the work for us at scale so we can focus on what's most important in patient care. Let's go to the voice one.
How long does it take to build a knowledge base?
The knowledge base of these? The great part about agents, I love that question. The great part about agents is we used to have to hard code everything, and it would take weeks. Right now, what we're showing you, especially from like a scheduling standpoint for an agent, we can build a full talk track and actually try to trick the agent, right? And that takes about 2 hours in an evening. And there's minimal code required now. That's how agents work. And so the video we'll show you now, as you listen in, this was built in about an hour using agent. Okay? So this is a patient calling in to schedule. We'll see if we can get the volume up high enough to have everybody listen, but this is a patient calling in and saying, hey, I want to schedule, and this is what the agent sounds like and what happens on the calendar as we do so. Okay? We're trying to trick it.
Thank you for confirming, Rich. Could you please share the reason for your appointment, especially if you're experiencing any physical pain or medical?
So really the cool thing about this that I find the most fascinating is everyone's called like the credit card support line or the Delta, the Delta chatbot, and if you're not saying exactly what they need you to say, right, it then either loops you, it drops you off, or it sends you to a human, right, or it just loops and says, hey, that is not a correct answer. Please go back to number one. This is actually a technology where we've taken an LLM, combined it with a chatbot, so that it can understand almost any context that any human, no matter their accent, no matter their language, the language they speak, and actually will respond to them in a way that makes sense, or performs a task within the EHR, the scheduling, in a way that's meaningful and prevents the need for a human to jump on it. Okay? Any questions about that?
So how advanced are you guys making this from the standpoint of, hi, I'd like to schedule the first time appointment, I'm not a current patient, here's my group information, here are the doctors available for your, for your particular insurance, here's the available time slots. Is it getting that deep? Or?
Yeah, exactly. So that's why we're talking about forward deployment engineering, right? We go to a practice and we say, what do you want the agent to do for you when they answer the phone? And then we dial in that talk track. We teach the agent through our large language model to answer those types of questions, and then we use your staff to challenge it and test it. Like, can you break the agent before we deploy it to your patient population? And so it gets very, very specific, and again, the coding is minimal downtime, right, compared to previous coding procedures that were involved in engineering. And so it's customized to each practice based on their needs, and again, documentation as far as scheduling, right, it can be clinical. And so we have another video we can show here where it's actually answering questions about what to expect for colonoscopy. But are they going to be more accurate than a front desk staff that doesn't really have a medical background that's trying to answer questions about colonoscopy? Probably, right? And so we use this also on after hours. We have practices that just turn this on 24 hours a day, nights, weekends, holidays, etc. And all of a sudden they have a call center, and every single call that comes through is recorded, transcribed, and then stored so they can reference it just to make sure they're accurate data.
I assume you have similar systems to deal with the two biggest issues at providers. Authorization is a huge one for everybody, and then denial management, because the insurance companies, they got jobs. Leave it that way, I'll be kind.
Yeah, in fact, let's do that video next. This is a non-verbal agent, right? So one more thing I'll say is we can take any one of your voices in this room and make it an agent.
Is the agent smart enough to recognize what Spanish speaking patient calls him?
Exactly right. So just like Scribe, 60 different languages agents can speak. And so same idea. Think about this at scale. How do we solve these problems, right? So any voice in here we can use and create an agent for. We have about 80 to be used right now. That can go as big as we want. And then we're showing you here it does not have to be voice specific. So let us show you how an agent does prior auth.
And a little background here for those who are like me and not as technical. There's a technology in the space called RPA, which is Dave, help me out.
Robotic process automation.
Robotic process automation. It's essentially a process where you can take a field that you know is on a specific website and train a platform to essentially click in that field and then input data that you have stored in a database. The problem with that model is as soon as a company or a website changes where that is, it breaks the automation because it's now putting it in a spot where that input spot isn't located. So the cool thing about these agents is we can instruct them, go to this website and fill out a prior authorization. And so what we're gonna see is you see these colors here. These colors are where the AI is reading each aspect of the website to know, okay, where do I need to put the username? Where do I need to put the password? So if the portal changed to where this was down here, it would never break the automation. We also don't have to spend the time building a specific path flow of where the information is put. You just give the data, you tell it what to do, and it comes and does it for you. So we'll watch this. It'll put in the username. It'll put in the password. It'll even do the two-factor authentication directly through a text message.
What happens if the Chinese get all this?
And book appointments.
Already have.
Hopefully they're virtual.
And then as you can see, it fills out the entire prior auth form for you.
Okay.
What happens when a medical director comes back and says, that's nice, but we're not authorizing this? And that happens, this particular treatment, that happens all the time.
Yeah.
Again, great question. Unfortunately, it's a part of the broken medical system, right? It's like we
Yeah.
can only control what we can control, which is using the tools we've been given to get prior authorization approved, and we submit based on how they told us to do so, and they're still going to say it's denied after we got prior authorization, right?
Yes.
And so, to answer your question, can we identify the denial faster, implement AI immediately, and shorten the time frame from a correction based on what they recommend, instead of just letting it sit? Because when you have humans running this on their own, they're always playing catch up. Right? They're working on the lowest hanging fruit, not on these outliers and time passes and then cash flow condition.
And this may not be, Yvette, who's an expert on this subject, are you paying attention, Yvette? She's an expert.
I was asking if it does a peer-to-peer review.
Yeah, that's what I was.
That's what I was,
Yeah.
we were discussing over here, sorry, I wanted to see where that level of what the AI does, if it has the capability of handling something of that nature.
Is authorizations a bigger problem than denials, or is denials a bigger problem? Or they're both bad?
I think they're both bad, but I think the denials where you're coming from the insurance companies, they're obviously playing games with providers now, and they're making it a lot harder for the providers to make the money that they're due. So I think that is a big, big issue.
You mean there's gambling in Vegas?
Absolutely. Isn't that fantastic?
Well, and they go hand in hand, right? You can have a denial type based on prior auth. Right, and so again, it's how quickly can you identify the cause, and then can you deploy technology, an agent, et cetera, to recommend a fix and to do it at scale, and then build a rule to not let it repeat itself as fast as possible. If you're having a human go through that process manually one by one, you're never going to stay ahead.
Half the time, the denials don't even follow policy. They don't adhere to policy, right? So you can use policy against them.
Exactly right.
Did you mention that it does referral processing?
Yeah, again, so that's the nice part about agents. Right now, our three main use cases that we're rolling out for practices as we speak, like I said, are scheduling, some clinical workflows, and then on the back end, answering questions on billing. So if they had a question on their EOB, they could call in, they could answer those questions and take a payment over the phone But again, use case is great. Peer-to-peer reviews, why not? Like let's train it. The nice part about technology is we want to hear the problems at hand. We want to take technology and build custom solutions for practice owners in large systems at scale. That is what we do best. We adapt our technology to current problems for active partners across the country.
The one other aspect of agents that I think are very, very soon or is being deployed right now is actually the auto generation of orders. So if I go in as a practitioner, I do an entire visit with my patient, I want to order this medication from this pharmacy, it will pick up that within the conversation and then automatically prep the order to go out, and you just have to click a button. For surgical, for pharmacy, for lab, for imaging. Again, it's an assistant to essentially make or eliminate the need for extra hands, extra touches on every single patient visit.
So you're talking about the AI effect on the insurance organization, and also you use them to interact with the patient. So how does it impact the staff in the office?
Yeah, it's a great question. I think, from a technology perspective from our company, we never want to tell a company what to do with their staff, right? We realize there are humans out there that are very, very skilled at the artwork of what it is billing, greeting patients, delivering high-level interaction with the patients. However, they're doing a lot of tasks that can be easily automated, right? There's a reason why we don't have phone operators anymore that you have to call into, and they put a couple switches in a circuit board in order to connect your call. There are things in healthcare that do not need a human to focus their time on. So some companies may decide, hey, let's repurpose some of these FTE hours to something that actually generates revenue for the business. Some may adopt our systems, and then over time, as people articulate, they don't rehire for that position. And then there are companies out there that say, hey, from a margin perspective, we can't maintain this number of staff. And so as we automate these tasks, then we can kind of move or repurpose it. So hopefully that answers your question.
I have a question. This may be a little bit off, but how does it have the system to where it can help the providers on the medication aspect from the insurances, because there's a lot of preferred drugs that have to be utilized prior to them being able to prescribe them that actually a medication that works for that patient, but they have to follow the system and guidelines of what the insurance will for them to use first. Do you guys have that capability of having that help the providers so they don't go wasting time on that off process to where they have to do this drug first, this drug, and then they finally can get into another drug that the provider wants?
So it's a work in progress. I don't want to tell you that it's completely out of the box, but we do have the ability to prompt a provider during the care on specific things that they should either do or bill based on insurance requirements. And that includes, potentially, referring to physical therapy first in some cases, or certain medications that they have to bill.
Well, and on top of that, think about Scribe. So we can use Scribe to say, what if we ingest clinical prediction guidelines? To your point, right? Like, we need these things to happen in order for this procedure to be rendered later on, right? Meet these requirements before this can be prescribed, etc. We build that in to then the point during care, you can actually have Scribe prompt the provider as they go through the course of care, and so you don't get to a point where you're too far down the path and the provider can't remember, and they're overburdened, like we said at the beginning of our discussion. They can't track all the things at the same time.
Yeah, because providers have a hard time understanding not saying all you guys, but on some level they have where they provide a drug that they're introduced by a rep that comes into the facility, and they love the drug. But then the insurance, when they give that patient a taste of it, and they're doing great, they go to do the authorization and they can't give it to the patient. Now they got to go back to a preferred drug and then build up from there, and then strip it from the patient, and then go back to square one in that treatment plan to where now the patient's not going to really feel good anymore. Now they got to go to some generics.
Broken medical model. Perfect example, right? Out of our control, here's what we do to help solve something, right? So same thing. Instead of having the provider immediately go to the drug the rep is introducing about, why not have a prompt in the system as he's rendering care during that encounter that says, in order to get to the point of prescribing said drug that the rep just introduced, these steps need to be followed first. Right? Check these boxes before prescribing said medication, or you're going to have to reverse or repeat the steps. And that interrupts the quality of care, right? That's a less ideal experience for the patient. But if we can prompt providers during the course of care to make sure they avoid that from happening in the first place, another use case for the app.
Couple, I know Dr. Fadiga was asking, when we had talked a few weeks ago, what overall do you see from people who are sitting in here that might be managing systems or large offices? Any studies or show about a reduction of staff or hours of time? I think we're the time value, RCM impact is about 25 to 30% offset. Is that fair?
Yeah, that's pretty accurate. It's pretty accurate. So for the systems and again, larger groups that we've serviced, it's about a 30% reduction. Now again, that's rough. That's an estimate because it depends on the setup. But what we do is we run an analysis. It's called a financial health analysis. We look at the current billing setup as it currently stands. We look at the charges versus their payments. We pull their AR analysis, right? And then we basically say, where is there room for improvement? And if we were to implement the solutions that some of these solutions, there's a lot of them we showed today. If we were to implement our platform into your system as it currently stands, what type of margins are there to gain? And that includes in the ROI analysis, just like the question was posed, potentially part of either a staff repurpose or a reassignment opportunity where they're focusing their time when you're paying somebody on revenue generating activities for the system and not monotonous repetitive tasks that an AG can do in 1/100th of the time or 1/100th of the cost of a human staff. So again, some use case studies, right? We have an ambulatory group, 40 locations or so in the Northeast. They had about 25 billers to start with. Within the first 6 to 9 months, reduced to about 4 or 5 billers total. And again, they decided to repurpose. Totally up to them, we don't tell them what to do, but potential use case for
in this town, we have a big shortage of staff. So repurposing them to do other effective things is a nice win-win for everybody. Can you go over the denials process? Getting denials, dealing with denials. Insurance companies love denials.
Yeah, I think we briefly touched on that video, the denials, right? So again, the way that works is you have a person who has to go and call the payer, right? And they have to spend a couple hours on hold. Can you pull up, let's pull up one of the agents. Do you have Hershey's deck? Sorry, we're going a little off script here.
No, but you did go over this, but I just want everybody to emphasize.
There's one video I really
big
like.
opportunity here.
So when it comes to working denials, as denials come back, the payer will do a couple things. It'll either pay it in full, it may do an underpayment or a partial denial, a full denial, or a thing called a no response. And a no response is an interesting conundrum because they don't tell you, they don't pay it, but they don't tell you why they didn't pay it. And it sits in limbo, and you have to actively call and ask, what is the reason or status of this claim? So when a human does it, they have to essentially go and either look at online. Savvy ones may ask ChatGPT, how I fix this denial. However, a lot of times you have to call the payer. So we're going to listen to a audio recording. You're going to hear two voices. The first voice is going to be the human for Blue Cross Blue Shield. The second voice is going to be one of our agents calling to ask about an updated payer ID. Okay, I might have to show you the audio at a different time. Is this document cool?
Well, this is the best part though.
Oh, it's not.
Where's AI?
You come to the next Game of Thrones
Where's
meeting.
AI?
All right, this is the cliffhanger.
This is the
In the next show.
By the way, agents in the Matrix were so good.
There you go.
Thank you, and as of today, I represent the Cape Philosophy Art Branch and Active Care First across Blue Shield Medicare Advantage, effective as of January 1st of 2023. And I'll be more than happy to check the claim status and what is the date of service for the claim cleared.
Does not like his job.
The date of service is December 20th, 2023.
Different voice for an agent.
Any bills amount, please?
Real person.
The bill amount is $390. Sir, but we do not have any claims on file for this number for December 20th of 2023 with a bill amount of $390. May I ask what address or payer ID you did submit that claim to, please? We submitted the claim to Care First Blue Cross Blue Shield Medicare Advantage. But what payer ID or address did you use, please? The payer ID we used is 7487. So I do apologize, that is the incorrect payer ID. For claims for services rendered in the state of Maryland, they must be submitted to the payer ID of S as in Sam, B as in boy, 580.
Okay, so to wrap things up. So I'm a biller. I didn't know how to fix that claim. I called. I maybe was on hold for about 3 hours till I got to this gentleman. That call was 1 minute and 25 seconds. I now have to take that information back to my EMR, find every single claim that I submitted to this specific payer with the wrong payer ID, and I have to go into each claim and type in this payer ID one at a time, in most cases. Okay? Going back to what we showed here with the Copilot, what happens is that comes back and it says, hey, this is how we fix this claim. We fix the claim, but then it will apply that to 25, 30, 45, 100,000 claims at the same time and resubmit it.
Wow.
And then it says, hey, if we're ever submitting to this payer again, make sure that this is the payer ID listed before it goes out, or stop it and allow us to fix it before it goes out. And that goes back to what Greg was saying about how we use this technology to build a data set that stays with your company forever, right? Improves over time, obviously manages the changes that the payers make, and ultimately doesn't put your clinic at risk for turnover from staff. So to wrap up here, because I know we're over time, but do you want to work?
Yeah, I mean, you guys are this one. I think the last thing I put to put on that question, I think this is a good way to wrap up, is think about that at scale. Think about your first time pass rates and how much they go up when you have a rule set when every claim is scrubbed before ever being submitted to a clearinghouse and get to care. So your first time pass rate starts to go up. Your denial percentage starts to shrink. Your aging AR goes way down. And your staffing needs are also reduced. What does that do to your bottom line revenue for a practice or system? And the question lastly is, what if that type of a platform or system was nearly the same or very similar cost to what you're paying now for your current platform using a large staff? And that's where it starts to become, hopefully in our opinion, a no-brainer to implement these tools. Is we're not going to implement them now, we're going to be behind. Because like we said at the beginning, the payers are using these tools right now against each of us. We need to be proactive and not reactive, and those who adapt and adopt early are going to stay ahead of the curve to not get behind in this broken system that we talked about at the start of our presentation.
And for the providers, the insurance companies are not going to up their reimbursement, even though in this town, typically they're below 100% of Medicare, which is atrociously bad. Then we don't have enough staff, so you got to throw that equation into it. Physicians who want to start up a practice independently aren't going to be able to do it because the insurance companies, even though they have inadequate panels for patient care, don't want to add anybody. the insurance companies have and I've been on both sides in my 47 years. I've run several large healthcare companies here. And the fact of the matter is, it's all weighted to the payer side. And having worked for casinos and funds and other things, they never ask are the providers being paid fairly. They have employees, they have a bottom line, and even the local insurance companies, not the local people, they got families, they got jobs, they got bosses, they're on bended knee full time. So you gotta have a tool, and I'm the least technical guy here in the room, you gotta have a tool that helps you combat these forces, because they don't care. They'll tell you they care. Your actions speak louder than your words.
Greg, could you touch on the financial health assessment? I know when people attend a lot of these meetings, they walk out, they gather afterwards, and they say, you know, I've been presented so many technology offerings in my career. We're all experienced health executives here. I just don't know that I can trust this. And how can you make them comfortable through the health assessment? What are you looking at? Is there a way to reduce the risk to them, to give them some assurance that this works?
Yeah, I think it's a great point. And again, dialing on what the financial health analysis is it's a way to create objective and clear value using your own system of practices numbers internally. This is not a projection of like, hey, this looks really fun and fancy, just throw it in there and hopefully it works well, right? There's risk to change in medicine, and as providers, we're very risk averse, right? So we recognize that, and so what we do is we say, let's take your specific numbers, it's like a 2-year trend of what you've submitted. Let's take Medicare's fee schedule and compare, because that's public, right? And compare an average of all the payer mix you have, what you've submitted charge-wise versus what you've actually been reimbursed, and to look for specific payers where we can do a better job using some of these platforms. And then we can take our historical data and say, hey, across all of our systems, we have a historical denial rate of under 2%. Yours is at 12. If we were to come to 4 or 5%, this is the ROI that would come from just an improvement in denial percentage. Or aging AR 90 plus, right? Or unpaid claims at 0%. And we put all of that together. And then we say, with these numbers, here's what we can guarantee. It's called an at-risk contract. Meaning we will put guarantees behind our technology to say, if you don't see this level of improvement, we'll take actually the risk. We'll actually decrease your rate or credit you on your bill because we're so confident that technology can improve your processes and your practice and your system, right, by using technology for things.
All right, thank you very much.